Welcome to Thinking Thoracic, the podcast dedicated to exploring the advancements in thoracic surgery. Brought to you by the Society of Thoracic Surgeons. This podcast features leading thoracic surgeons discussing and debating the latest research, surgical techniques, and trends to expand your knowledge, challenge your thinking, and help you stay ahead of the curve. Whether you're a thoracic surgeon, advanced practice provider, researcher, or industry professional, Thinking Thoracic is for you. Let's get started. The Society of Thoracic Surgeons Thinking Thoracic podcast is sponsored by AstraZeneca.
Welcome to today's Thinking Thoracic episode, where we'll be discussing the new STS General Thoracic Surgery Risk Calculator and short-term risk models. I'm your host, Jeff Yang, and I'm here with Dr. Chris Seder, who is the Arthur E. Diggs and L. Penfield Faber Professor of Surgery and Chief of the Division of Thoracic Surgery at Rush, and Dr. Robert Habib, who is the Vice President of Research at the STS and oversees the STS Research and Analytics Center. Chris and Robert, welcome.
Thank you.
Great. So, Chris, I know you're the chair of the General Thoracic Surgery Database workforce, and you and the workforce have done terrific work over the past several years. Can you share with our audience, what does this workforce do?
Sure. Yeah, the mission of the workforce is pretty simple. We're responsible not only for the maintenance and the updating of the General Thoracic Surgery Database, but most importantly, figuring out ways that we can use the database to provide value to our participants. And what that generally looks like is quality improvement initiatives, as well as various research initiatives.
Wonderful, thank you. And Robert, can you introduce what the STS Research and Analytics Center does?
Yes, absolutely. I'm happy to. The STS Research and Analytics Center really oversees a number of research programs, including programs that we make available data to investigators outside of the STS through the Participant User File program, as well as multiple programs where STS Research Center team members and statisticians are actually perform the analytics, all to answer hopefully important questions relating to all our subspecialties: adult cardiac, general thoracic, congenital heart, and even in the MCS space. We also do a little bit of research with industry, as well as have active grant funding activities as well.
Thank you. And with regard to this new General Thoracic Surgery Risk Calculator, Chris and Robert, can you tell us a little bit more?
Sure. Yeah. This has been a really exciting endeavor that we've undertaken with the Analytics Center, and there's been a lot of work that's been put into it, and it all really, started with us revising the short-term risk models for both pulmonary resection as well as esophagectomies. And the last risk model that had come out had less patients, it had older data, and there'd been a number of changes in practice patterns. We observed greater than a 500% increase in robotics between 2013 and 2022. We know that people are using more induction therapies. There are a number of new systemic therapies that are being used. And so with over 800,000 patients in the General Thoracic Surgery Database, we wanted to create a risk model that would minimize the exclusion criteria used in the previous models, making the model more inclusive. And importantly, we had plans to create this risk calculator. And so we only included preoperative variables in the risk in the risk model. And that's going to be important, when we come to talking about and creating a risk calculator, because it only makes sense that you would use preoperative risk factors in a risk calculator. Plus, we knew that there are a number of new variables that should be included in our risk models, based on more recent literature, things like body surface area or ILD or payer status. There's a lot of good data that show that these do correlate with short-term outcomes, and so we included them. Now, these new risk models ended up having 4 to 5 times the number of patients the prior models had. And this resulted in improved C statistics in both the pulmonary resection as well as the esophagectomy risk models. And so those risk models were then used to create this short-term risk calculator that we're talking about.
Great. Thank you, Chris, for explaining that. And Robert, can you explain the methodology used to create the models behind the calculators, and including, I know our audience is thoracic surgeons, but feel free to go into the weeds a little bit and explore and share with us some of the technical details of the model development.
Yes, absolutely. Happy to try and do so. Risk model building is a strength of the STS. In fact, STS has been in the business of risk model building for more than 2 decades. And importantly, the STS Research and Analytics Center is building on that experience. All our risk models have to go through a very rigorous model building, set of steps. Okay. Most importantly is what Dr. Seder just talked about, which is the STS database and the quality of the data we have in the STS database. The fact that we have hundreds of programs contributing data that is audited and high quality data is the cornerstone of any good models and model building. We leverage that wealth and breadth of data in order to build these models. And when we do so, we actually are using very rigorous methodology. First of all, we are very methodical in the inclusion-exclusion criteria. For example, again, what Dr. Seder just mentioned, we wanted our models to be expanded to be more inclusive and more representative of the general practice. For example, and let's take pulmonary resection as an example for this audience. When we have this population, we methodically then split it into derivation subpopulations and validation subpopulations. We use a multiple sets of validation steps. We are very focused on making sure that the models that we are building are actually representative. And what do I mean by that? A good model, first of all, has to be highly discriminating. And this is, again, the C statistics, or the area under the curve, which is basically combining the model sensitivity and model specificity in a unique way in order to give us an estimate of the discrimination power of our risk models. A good model should be highly discriminating. I'm happy to report that STS risk models generally are perform very well to excellent. After we derive the model, we apply it in a validation cohort and make sure the model is equally discriminating and performing in the validation cohort. We also do methodology, without going too deep into it, of ninefold cross-validation to also further confirm the robustness of our risk estimates and robustness of our model structure. Lastly, and this is a very critical and maybe perhaps a unique step that we've more recently added to how STS builds and tests its risk models. And I'm going to try to take half a minute to explain. So we build a model, we validate a model, and we are happy with the performance, general performance of the model. After we do that, we comprehensively test it in patient subgroups. For example, let's take we have a pulmonary resection model. We have lobectomies, we have segmentectomies, we have wedge resections, bilobectomies even. So a model that is performs very well overall, especially when we have a dominant procedure such as lobectomy, okay, is not necessarily true in the subgroups. Well, STS is not satisfied to make sure that there is overall good performance and calibration. We actually make sure that we are well calibrated in all procedure type subgroups, demographic type subgroups, men and women, older and younger patients. We also, tumor location, tumor size, staging, nodal involvement or not. So STS models have been very well tested. And I'm giving it here the pulmonary resection, but we apply it across the board in population subpopulation or subgroups. So to make sure that we are putting out there the best models and hence and subsequent to that the best calculators possible.
Thank you. I appreciate you for giving us a little bit of the behind the scenes look into this. Now, the models also use O to E ratios, and this is a term that we often hear about. Can you explain what O to E ratios are, how they're calculated, how they're used in this risk calculator development?
Yes, again, absolutely happy to. And I failed to mention earlier when you asked me about the STS Research and Analytics Center, what our functions include. A big and very important function that we do is we run the STS harvest analytics for all STS databases, inclusive of the General Thoracic Surgery Database. So going back to your question of what are O2Es and how do we use them and how do we best understand them, a good way, at least the way I like to explain it, is that let's use a simple example, okay? Let's take a hypothetical hospital A, okay? This hospital A performs 100 pulmonary resections that meet the inclusion criteria of the STS analytic data set. So we always analyze over a 3-year period. So let's say 100 times 3, that's 300 cases from hospital A made it into the analysis. Okay, so hospital A experiences 3 operative or 30-day deaths over this 3-year period. That's a 1% operative mortality rate, 3 out of 300. Our STS pulmonary resection model will predict for each one of these 300 patients, based on their demographic factors, their risk factors, their comorbidities, their tumor specific details, okay? We will predict a estimate or a predicted risk of mortality for this individual patient. And therefore, we have 300 such estimates for all 300 patients. We average those 300 values, and I'm going to, so we talked about 1% observed mortality. Let's say this average, after we get these 300 estimates, the average ends up being 2%. instead of 1%. Now we are in the realm of O to E ratios. Okay. So what is the hospital A observed to expected ratio? It's simply 1%, which is the observed rate, divided by 2%, which is the average or expected rate. So this hospital A has an O to E ratio of 1/2 or 0.5, which is less than 1. That's typically an excellent outcome, okay? And this is a hospital that is overperforming. Lastly, let's take the reverse example where actually when we average the 300 values estimates, we get an estimate of only 0.5%. So this is a hospital doing predominantly low-risk cases. Now, the observed to expected ratio is 1 divided by 1/2, which is an OE ratio of 2, which is greater than 1. And that is a value suggesting an underperforming hospital. I hope this was helpful.
That definitely was helpful. And then how are the O to E ratios used in the risk calculator development?
They are actually not used in the risk calculator specifically. The risk calculator is going to allow a surgeon or a data manager to actually input the specifics of the patient and get the risk estimates for mortality or morbidity, or mortality and or morbidity. Okay, so the O to E ratio concept is more towards quality measurement and more towards is used in harvest analytics and rating of the performance of programs. It's not at the used for specifically as part of the calculator because we obviously don't know the observed value for a patient, if that patient is going to experience an operative death or not. But Chris, maybe you have something to add on that.
First thing you should know is where can you find the calculator? If you go to the STS main website, the easiest way to find it is just click on the tab that says risk calculator. There's a number of cardiac risk calculators. There's a number of thoracic risk calculators. You can choose on either the pulmonary resection risk calculator, or you can choose the esophagectomy risk calculator. And once you click on that, it takes you to the calculator itself. And it's a really cool setup, and it's quite intuitive and quite easy to use. As you click through each of the variables on the risk calculator, you have a second panel or pane on your screen that tells you what the estimated operative mortality and estimated morbidity and mortality are. And they give you there's confidence intervals as well that go along with each one of those estimates. So, for example, if you go to the pulmonary resection risk calculator, you can click on wedge, lobe, bilobe, segment, sleeve, pneumonectomy, and then you go through the rest of the calculator and indicate, well, I did this robotically and not VATS, and it was a reoperation, and the patient's ASA and ECOG scores were this and that, what the patient's sex was, what their height and weight were, what was their payer. And then you get into some specifics about tumor staging, so clinical cancer staging. And this is, again, a preoperative variable, unlike the old models that used pathologic cancer staging, which, of course, we don't know preoperatively. The tumor location, whether or not the patient got induction therapy, and then a whole list of comorbidities, including functional status, FEV1, DLCO, and a number of comorbidities. And all of those will be listed out. Everything that you enter will be listed out as basically a patient description and associated expected morbidity and mortality for that given patient. And it's really cool because you can copy it, paste it, give it to your patient, or share it with a referring provider, or just have that knowledge for yourself. And when we were initially talking about, how how are people going to use this calculator? And what's the real value that it's going to provide? The scenario in which I think it's, most uh, applicable and most useful and provides the most value for our participants is, we're constantly having this debate about sublobar resections versus lobectomy, or wedge versus segment, or segment versus lobe. And you have let's say you have a 1.5 centimeter tumor, but it's mostly solid, and you're thinking, should I do a lobe or should I do a segment on this patient? And you can go into the calculator and enter all the patient's demographics, comorbidities, the tumor characteristics, and then just toggle between wedge, lobe, and segment, and you will see a different risk estimate for morbidity and mortality for each of those three operations. And so you can use that as a general guide to gain more information about, what the expected risk is for that given patient with those comorbidities, based off of, nearly 1 million patients worth of data.
Thank you both, Chris and Robert, for explaining that. And it's certainly very exciting calculator. Is there a mobile app available for this risk calculator?
So yes, there is. It's in active development and beta testing right now. The app will be available to, participants and STS members in the second half of June.
Great. And who do you think would use these risk calculators? Is it just the thoracic surgeons, or do you think that other providers or even patients can use this?
I certainly thoracic surgeons will be the majority of people who are using this risk calculator. I would not expect many patients to, for example, go through a risk calculator like this and kind of understand what their ECOG status is, what their ASA status is, what is their FEV1 and DLCO. There are some patients who are that sophisticated and know the maybe the medical side of some of this, but most probably will not. I think that there's a minority of maybe radiation oncologists or medical oncologists that would use this. I think that that's probably the primary group of people who will make use of the risk calculators.
Great. So thank you, Chris and Robert, for explaining these risk calculators and developments. Now, everything we've talked about so far is just looking at the short-term risk. Are there plans to create long-term risk calculators now that the General Thoracic Surgery Database has incorporated long-term outcomes?
Absolutely, Jeff. And that's one of the things that we're really excited about. So at this last STS annual meeting, we presented our, the first paper that incorporated National Death Index overall survival data, as well as CMS outcome data with the General Thoracic Surgery Database. And we, close on the heels of that paper, is the development of the long-term risk models that will not only be used for risk calculators, but also eventually long-term harvest analytic models. And so that's that is absolutely kind of on the docket, and in not just on the docket, but in process right now.
Wonderful. That's really exciting. Now, there are so many factors that go into long-term survival. How is the STS trying to account for these factors when they're doing their model development and calculator development?
Yeah, that's a great question, Jeff. Especially when you look at the list of things that go into the short-term risk calculator, you don't see many of the factors that you would expect to be associated with long-term survival. Historically, the STS General Thoracic Surgery Database has been a short-term. It's been a 30-day outcome, 30-day outcome database, and I think that we got to the point where we demonstrated that STS participants do really safe surgery in 30 days. And kind of everybody knows that now. And the next, obvious step is, so how are these patients doing in the long term? And since we are talking about cancer here, and we are, surgical oncologists at the core of it, so it's a good observation that those current predictors of short-term outcome may not necessarily be the same as long-term outcomes. And for that reason, when we were at the point where we were about to incorporate long-term outcomes, we spent about 6 or 8 months revising the data collection form for the General Thoracic Surgery Database. We kept all of the known factors associated with short-term outcomes, and we incorporated additional factors or that may be associated with long-term outcomes. Things, for one of the primary examples of that are many of the pathologic factors we know are associated with long-term outcomes, like size of margins, STAS. There are radiographic features that we know are associated with long-term outcomes, like FDG avidity. These are the types of things that we've incorporated into the database, so that as time goes on and we collect additional data using the new data collection form, that we can expect to create risk calculators and risk models that perform better and better, because we're putting the best data in there that the current literature shows us is associated with outcomes.
I appreciate you for explaining that, Chris, and can't wait to see that long-term risk calculator. It's certainly going to be a very important development.
Yeah, and if you kind of imagine now, again, the same scenario of toggling between patients, you might see that, yeah, I could do a wedge resection with a shorter, with a better short-term survival, but perhaps, and maybe not, the long-term survival isn't as good as a lobectomy, and that's what that's what we're gonna try to provide to STS members through a combined short and long-term risk calculator.
Absolutely. I think that's going to be really exciting. Robert, you've been doing this really innovative research with STS Research and Analytics Center for several years, and now with the risk calculator developments. What has been the most interesting and fun parts about these projects for you, and where do you see the next 10 years being like for you and the STS Research and Analytics Center?
Yes, thanks, Jeff. I'm really being honest here. One of the most enjoyable parts of it has been working so closely with Chris, Dr. Seder, and he's been joy to work with, and very insightful and very helpful to us. That do not have the knowledge, the clinical knowledge. This partnership was very enjoyable, and I like to believe very successful, and that is very satisfying. And also the fact that we've been able to incorporate the National Death Index data, late outcomes, and now looking forward to working with Dr. Seder again on developing the first generation risk calculator, long-term risk calculator, and risk models. I say first generation because I want to be sure that to mention that we won't have the benefit of leveraging the hard work of the General Thoracic Surgery Database workforce and their update of the data collection, the recent update, which added a multitude of fields that we know are important predictors of long-term outcomes. It's going to take us a few years, but at least we started this journey, and it's really we're looking forward to it and to taking it together. And we welcome you, Jeff, to join the team as well. So thank you.
Thank you, Robert.
Well, thank you very much, Robert, for those kind words, and I do appreciate that. We have done really good work together. However, it is necessary to acknowledge the General Thoracic Surgery Database workforce. We have over 30 team members on the workforce who are, doing the lion's share of the work related to these risk models and quality improvement work. So I do thank my colleagues on the workforce that do all things database related.
To our amazing listeners, thank you so much for joining us today. If you have enjoyed the conversation, please be sure to follow Thinking Thoracic on your favorite podcast platform so you never miss an episode. Your support helps us to continue to grow, improve, and to bring you the most insightful conversations. And if you have a moment, we'd love for you to leave a rating or review. It really makes a difference. Thanks for tuning in, and we'll see you next time.
Thank you for joining us on this episode of Thinking Thoracic. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons.